Hi everybody and welcome to the Kidney Coach YouTube channel. I am Fiona Chin. I realized I never introduced myself on these videos. I always introduce you. So my name is Fiona. If you go back to some of the previous early videos, you'll get an understanding of who I am if you don't know who I am. And I'm joined by the amazing, beautiful Emily Cahill. Emily is part of our Kidney Coach team, like me. She's a qualified naturopath, but Emily is also a qualified nurse, and she has a special interest in kidney disease and oncology. She works in a large cardiovascular unit in a large hospital here in Melbourne. And also if you want to know more about Emily, if you head to our website, www.kidneycoach.com, and hit articles, you'll see her beautiful smiling face there. She has written the majority of our recent articles, as well as all our Facebook pages. She may have answered an email if you're emailing our Beat Kidney Disease Solution team. And if you've had any questions about some of the supplements, that'll be Emily that's getting back to you. So she's a very active and valued member of the Kidney Coach community, and we often don't know what we do without her. So we are very lucky to be joined with her today. So one of the things that Emily and I really wanted to talk about was this thing called the triple whammy, and just the effects that those and we're referring to 3 medications that we know has an impact on kidney function. And I don't know about you, but it's probably when I see people with kidney disease, I would say, and I'll tell you, I'll get you to tell me what you see, Emily, but I would say 50% of the people that I see with kidney disease, their kidney disease, yes, will be sitting along things like cardiovascular and diabetes, but when you look at their history, they've got a triple whammy in there. And generally, I suspect, yes, it'll be part of the cohort of diseases that go with kidney disease. But often I'm thinking it's generally induced by this triple whammy effect. So do you want to tell us what I'm talking about when I say triple whammy and what medications they are? And we'll start there.
Okay, cool. So the triple whammy is, as Fiona said, so it's 3 medications that can be prescribed together. So the first one is actually 2 classes of medications, and that's an ACE inhibitor, so angiotensin converting enzyme inhibitor, long word. ACE inhibitors are your blood pressure medications that end with pril. So ramipril, enalapril, perindopril, they're all classed as ACE inhibitors. The second class that are very similar to ACE inhibitors are angiotensin receptor blockers, and they're your medications that end in TAN, so candesartan, losartan. They're generally used as blood pressure medications. They are often used in people with heart failure, and they're also used in people with kidney disease. So that's the first class. The second one is a diuretic. So diuretic is, it's often spoken about as a fluid tablet, and that's a medication that you take to get rid of excess fluid, swelling or edema, again, used in people with kidney disease and often used in people with heart disease as well. Then the third medication class is our non-steroidal anti-inflammatory drugs, or our NSAIDs. So they're often used for things like pain or inflammation. So what's called the triple whammy is when someone is taking each of these medications at the same time. Now, the reason why the triple whammy is problematic and why it's something that you need to be aware of is that it is probably the most common definitely in terms of medications, but one of the most common causes of acute kidney impairment. So we've got chronic kidney disease, and then we've got acute kidney impairment or acute kidney injury. And that's when your renal function drops acutely, so within a matter of a day or 2, and quite dramatically. It's often a reason where people have to be admitted to hospital for treatment. And it is more common in people with chronic kidney disease to develop acute kidney injury at some point, but it can happen to sort of anyone in the population.
Now, here's what I find interesting is lots of people with chronic kidney disease have concomitant heart disease or high blood pressure. As we know, those go together. So they're put on diuretics and they're put on ACE inhibitors. And then often what happens is, I find they may have decided to go on an NSAID, generally prescribed by their doctor, and it's sometimes not checked, or a different doctor, because they're just going for a bit of arthritic pain or something like that. And then you get this triple whammy, which good pharmacists and doctors should be flagging that, especially if people have already pre-existing kidney disease, or if they've got cardiovascular disease and they're not having their EGFR checked. So since we know the triple whammy effect and what happens, why do you think, is it they're not given, there's not another option out there, like using, say, a calcium inhibitor or something like that, one of these other classes of drugs? Why is it that when we know that triple whammy for people, especially with existing cardiovascular disease, people are still prescribed this concoction? Why is that?
So I guess the reason why people are still prescribed diuretics and angiotensin converting enzyme inhibitors, and that's sometimes called a double whammy, in these sort of conditions, is that I guess a lot of the time, unfortunately, they're necessary. So diuretics, more so for people with heart failure, are necessary a lot of the time in order to maintain their fluid status, so that they're not ending up with fluid on the lungs and, a lot of swelling in the legs and things like that. Angiotensin or ACE inhibitors are prescribed a lot in kidney disease. And it's that thing of, they can be helpful to the kidneys, but they can be harmful to the kidneys. So they are prescribed because they can reduce the loss of protein in urine. Mm-hmm. So that's the reason why you'll often see people with kidney disease on ACE inhibitors, even though you might sort of think, well, hang on a second, if they can be harmful for the kidneys, why are these people being prescribed them? But it's because that there is also, research behind their use in kidney disease. Now, the problem with them is, or the way that they work, is that they will often cause an increase in creatinine when someone goes on them. So creatinine being one of the waste products in the blood that the kidneys filters. And so often when people start on them, they will get a reduction in the creatinine and so a reduction in their EGFR. But that is seen as being almost like a necessary evil for longer term benefits. So the reason why I guess it's accepted is that, yes, you might have a reduction in your kidney function, but the hope is that it will stabilize your kidney function for longer than if you weren't taking it. Does that make sense?
Yep, it does. And is that what you see? Is that being in a cardiovascular ward, if you have someone with, blood pressure issues that we know uncontrolled high blood pressure is definitely going to speed up the decline of kidney function, do you find that people on that, even if they're on a double whammy, do you find that the theory of it preserving kidney function, even though the creatinine's gone up, which will automatically dump your EGFR, that's how we work out what an EGFR is basically, do you find that that is true? And is that what the studies show? Because we often know that sometimes they don't match.
Yeah. I guess it's the tricky thing is, how can you say for certain that if you put someone on an ACE inhibitor and a diuretic, you don't know what the trajectory of their kidney function was going to be. So how can you say for certain that it's better than it would have been, if that makes sense? I guess a lot of the patients that I'm seeing in the hospital are on multiple blood pressure medications, multiple different classes, often more than one diuretic. So again, it can be a little bit hard to work out, well, what's actually affecting their kidney function. Like we know, particularly certain diuretics, we will put people in heart failure into acute kidney impairment. And that happens quite commonly in hospital, while trying to deal with their fluid status. So it's that balancing act a lot of the time. I know particularly, you know, and I guess I'm talking more so about patients with heart failure and kidney disease, that it's sometimes a really difficult balancing act of, we need them to have less fluid on board so that they're not so short of breath, so that they can walk around, so that they can, you know, they're not stuck in bed or in a chair and all those sorts of things. But in doing that, we're actually really affecting their kidneys.
What is the lesser of two evils, right? Because,
yeah,
you know what I mean? Like, we don't want someone to drop dead of a heart attack because we couldn't control fluid, but then we know the long-term devastating, debilitating effects of kidney disease. And in the Western model, kidney disease is incurable. We have a very different view of that because we, especially when it's drug-induced, I have to say kidney function actually can bounce back quite quickly. In my experience, when it's medication-induced and it's more that acute phase, you can actually reclaim that loss of kidney function. So what do you say? I mean, you're in a cardiovascular ward. Are your cardiovascular guys more likely to pass away or die of cardiovascular events, or are they dying because of complications of things like kidney disease? Sorry for a morbid question, but I guess people would have to know that.
Yeah. I would say probably, well, it's hard because I do go hand in hand. I would say probably more commonly cardiovascular type events. And I guess, you know, particularly when I'm talking about that, you know, really severe heart failure, that end stage heart failure, where you're trying to sort of balance their fluid and their needs there, then generally it is more heart failure related deaths.
Okay, so let's take a step back and go, okay, end-stage heart failure totally makes sense. The triple whammy may be an evil necessity because you're prolonging life there, and a little bit of kidney function or loss of kidney function and dialysis versus dropping dead of a heart attack may be the lesser of two evils. Now, what I see is I see people not in end-stage heart failure, but I see people with high blood pressure. And what I see is the triple whammy plus statins. So I will see that ACE inhibitor, a diuretic, an NSAID, and a statin drug. And I'll generally see those four. And these people generally will have a history of high blood pressure sitting 130 on 90. They'll be on multiple, generally, blood pressure medications. They've got maybe some elevated cholesterol. When I say elevated, 6.5. When I came out of uni, that was in the normal reference range, and that seems to move every year. Don't start me on statins. And then they've got a bit of arthritis, and so they're taking that as well. And then, I'm thinking of this because I had a new patient last week, and he came in and sat down, not for kidney disease, for all this other stuff. And he had a very dry leg with a certain rash on there. Now, I can look at that rash straight away and know that's kidney disease. I know exactly what that is. And I'm like, well, you've got kidney disease. Has anyone checked your EGFR? No, we go down and do it. And he's in stage, nearly stage 5, kidney failure. No one's checked. And there's no doubt in my mind that's drug induced. Now, yes, he was blood sugar levels and cardiovascular disease, but I go, and it's, again, that rash that they get on their leg. Generally, I know that's medication-induced. So what do we do with those patients? Because, therefore, that triple whammy may not be justified. They're not likely to drop dead. He wasn't going to drop dead in the next couple of days or so from heart failure. In fact, his was very lifestyle-induced. What do you do when you see those types of patients where you know that combination that they're on quite likely is going to shorten their life because of the loss of kidney function? Where do we justify that? Where does that sit in? Because that's what I would see. I don't know if that's something you see with patients coming through.
I mean, I think there's not many reasons why someone should be on an NSAID. I think there are other things that can be used. So I think that's the first one that always should go. And I guess probably from my experience, what I tend to find more is that people are on the double whammy. So they're on the ACE inhibitor and the diuretic, and they've had a bit of pain. So they've gone to the chemist and they've got something over the counter, not realising, maybe not realising that it is a non-steroidal anti-inflammatory, or not, obviously not realising the potential for damage with the other medications that they're on. So I think the first thing is get that one out if you can.
Yeah. So let's go quickly while you're there. What are some of the really common over-the-counter NSAIDs that people might not even be aware, NSAID being non-steroidal anti-inflammatory drug, that are NSAIDs?
Yeah, so probably the most common one and the easiest to get over the counter is ibuprofen. And then you've also got things like meloxicam, but that's prescription. Voltaren is another one that I know in Australia we can get over the counter. I'm not sure about other
US as well, it's over the counter.
Okay. They're probably the most common ones. And then, often you'll start to see things like ibuprofen in a cold tablet. So you might just be thinking you're taking something because you've got a bit of a cold without actually knowing that it's got a non-steroidal anti-inflammatory in it at all.
Yeah, okay. I interrupted you before to go back to those drugs, so keep going if you remember what you were talking about.
So Voltaren, ibuprofen, meloxicam, what are some of the other ones? High dose aspirin. So, not talking about sort of baby aspirin, as people sort of call it, but yeah, higher dose aspirin is a non-steroidal. They're the main over-the-counter ones that we can get here. I'm not sure about other countries, but they're probably the most common ones I would see. Ibuprofen probably being, and Voltaren.
Yeah.
Being the two most common that I would see people self-prescribing.
Yeah. And what about, as people will ask, what about the topical Voltaren skin rub? I mean, obviously we know the skin is the greatest absorption organ in the body. Do you see that topical application of non-steroidals will still have the same impact as ingested?
I think if people are using enough of it and over a longer period of time, then yes.
Yeah. So again, people, those just skin rub, there's in Australia, they're called Voltaren skin rub, and it's got a different name in the US, and I can't quite remember it, but I've seen it there. That will contribute to a triple whammy if you've got sore joints. So I think I'd asked you what other options people have with that. So you were talking about taking out the non-steroidals and that sort of stuff. So keep going down that line of, again, because that's what I see with kidney disease, definitely people on those 4 drugs, so the triple whammy plus a statin. And as you said, we know non-steroidals probably for pain, apart from all the other side effects like ulcers and all of those sort of things, we know that there's probably things more effective. What about the double whammy? And how, can we get around that? Long term, you talked about acute kidney failure. I personally believe it contributes to long-term chronic kidney failure and declining kidney function, because I know when you take people off them, even though it doesn't look like acute and maybe their numbers are sitting around 50, 40, you take them off the double whammy and their kidney function comes back to normal. Is that something that you've experienced? And if so, what are some other alternatives and things that people might be able to do to help support cardiovascular health so they don't need to rely on this double whammy?
Yeah. And I think that's the key. Like, what else can we do so that we are still having the actions that we need, that we are still lowering someone's blood pressure or reducing their swelling, so they don't need these medications. In terms of, I think, we did a video on cardiovascular disease, but some of the herbs and nutrients that are helpful for blood pressure, like magnesium, hawthorn, donshen, excuse me, nettle leaf can help with swelling and fluid. I actually read an interesting study about the diuretic portion for people with kidney disease, that it showed, it was quite a large study, I think it was a population study, that being on a diuretic, even if it, say did lower blood pressure somewhat, people that were on the diuretic actually had worse outcomes than people not on the diuretic in terms of kidney disease, and they died earlier. And also were more likely to need dialysis as well. So I thought that was really interesting when we're looking at
Yeah, and I'm sorry to interrupt you. I was going to say that makes sense because a diuretic is going to force the kidney to filter faster. I mean, that's what's flushing more fluid through the kidneys to take fluid off everywhere else. So that totally makes sense to me because suddenly you've got kidneys that may not be up for the job of being, it's like you're cranking up, putting more coal into a steam engine of something that just can't keep up. So that totally makes sense to me of why that'd be the case. So sorry, keep going.
Yes, yeah. But I think that's, interesting because, again, if someone has high blood pressure, then there is a bit of a checklist that doctors go through. Okay, so first I put them on, if it's someone with kidney disease, it might be first I put them on an ACE inhibitor. Blood pressure doesn't quite come down. Second, I put them on, calcium channel blocker, or second, I put them on a diuretic. It's almost like this tick box of going down the list. But, the question is, well, is it really helpful? And is it really necessary? And is there another way that we can do this that isn't going to be as damaging? And I think that's sort of the key. And unfortunately, yes, we have these studies about ACE inhibitors and kidney disease that, yes, there's positive and negatives, but we don't have a study of an ACE inhibitor against a herb. So, that would be something I would like to see. Yeah. And see sort of the difference there because, we're studying things against placebo. So yes, an ACE inhibitor against placebo may not be as, might have slightly better outcomes than not doing anything at all. But what if we actually did all of these other things that weren't going to be damaging?
So what are the options that people have if they're prescribed a triple whammy and they know that they've got kidney disease? What advice would you give to someone that they're listening to this and they're like, well, I'm doing all of that and I've got kidney disease. Why has this not been flagged? No wonder my numbers are dropping. Like, how would you address that and what advice would you give to those people?
So I would be telling them to speak to their nephrologist or their primary care physician. Again, sometimes it's that people are prescribed, the diuretic and the ACE inhibitor by their nephrologist, and then they go to their GP, or maybe not their usual GP, they go to another GP and get prescribed their non-steroidal. So it may be that their primary doctor isn't aware of everything they're taking. So that would be the first thing. If they are aware that they are taking the triple whammy and it is someone with kidney disease, then I would be asking, could this be affecting my kidney function? Can I come off the non-steroidal? What are my other options? Obviously, if you've got pain, then we need to address the reason you've gone on it in the first place. But actually asking the question of why am I on these 3 drugs? Is it really necessary? Is there any way I can drop 1 or 2? And how do we go about doing that? And sort of start there. The other thing I always recommend to people, particularly people with chronic health conditions, and so particularly people with kidney disease, is only go to one pharmacy. Keep all of your scripts with one pharmacy, get all of your medications dispensed at one pharmacy, get all of your over-the-counter meds at one pharmacy. Pharmacists are really fantastic at picking drug interactions, including with over-the-counter. So that can be a way to, if you're not aware of that you may be taking a non-steroidal, the pharmacist can be that person to flag that with you as well.
Yeah, that's really great advice because that's what pharmacists are trained to do. And in fact, one of the things I often get patients to do if they're on 4 or more medications, because again, it's something I see is often the medications are interacting, causing their own side effects. They're taking another drug because they can't sleep. And that'll be a combination of the statin and the SSRI that they're taking. And so I just did this last week. I had a patient on about 12 medications. And when I looked at them all, there were drug interactions and they're not being picked. So a good pharmacist, you can send them back and they can do a pharmacist can do a review and then send a note back to the doctor with recommendations of what needs to come out and other possible solutions. So yeah, very good pharmacist. That's where their expertise are and they can be definitely very useful in those kinds of cases. The only other thing I wanted to add is, okay, we've got the triple whammy and more acute kidney disease. Do you think any of these medications long-term can contribute to chronic or a decline in kidney function?
Yes, yeah, they can. So, you know, any of these medications on their own can, excuse me, cause, well, start with acute kidney injury, but can reduce kidney function and nephron loss over time. So I heard about a client the other day who, only a young person who's got, you know, really reduced kidney function. It was just put down to, he took ibuprofen for a long period of time, you know, 10 years ago or so. So any one of these can contribute to kidney disease.
And I think that's the thing to know is when you're taking drugs and medication, they're all being filtered through your kidneys, and things like diuretics, which are going to speed up the filtration process. If you've already got a kidney that's maybe a bit sluggish for whatever reason, and you're asking it to do more work, especially when you're changing blood pressure, because kidneys and angiotensin 2 and things like that are regulating blood pressure. So you're going to have a feedback through there. And then we know the non-steroidals have quite an impact. And antibiotics are the other thing I often see will have a massive impact on kidney function. Things like Careflex is what we call them in Australia. One of the side effects is kidney damage. Any other drugs you want to flag that you know have long-term side effects of kidney damage?
Yeah, there's quite a few of the antibiotics, then chemotherapy type drugs as well, and some specifically cause kidney damage. They'd probably be the primary ones.
Yeah. So if you've been diagnosed with chronic kidney disease, one of the things a good nephrologist or naturopath or integrative doctor is they should take a full history of your medication and what medications you've been on. Again, I would say 40 to 50% of the kidney disease patients that I see in clinic, when you take a case history, for me, they're often, yes, lifestyle, poor dietary choices, blood sugar, uncontrolled blood pressure, but maybe not crazily high, but generally they'll have this concoction of medications in there, and I'm often wondering how much of those medications are contributing. And if you've got weird leg rashes, what happens I see is the skin on, I don't know if you've seen this, Em, but the skin on the legs go really dry and it starts to peel and flake, and they can almost get that, the skin goes dark. It almost looks like it's starting to get that gangrenous look that diabetics get, where the poor blood flow in there. And generally these people have type 2 diabetes and things like that. But for me, that's generally a flag of medication-induced kidney disease. And you can, if you can work with their GP or nephrologist and reduce doses, and while you're doing lifestyle stuff, you'll often find that rash, it's a really weird scaly skin rash, tends to go away. And that for me is a massive flagger of medication-induced kidney loss of function. So make sure that you know, yes, medications can sometimes be super useful, but especially because the kidneys are going to have to filter them, they can make them worse. So always good to discuss with your doctor or a really good integrative GP or naturopath that can review all of that for you. And, you know, as we know, there are plenty of natural alternatives that may be just as effective, that it might be worth trying and giving that a go to see if you can come off some of these things and preserve your kidney function. Anything else you want to add, Em?
Probably just the other thing, for people who are on the double whammy, or certainly on the triple whammy, but even the double whammy, is to speak to your doctor or pharmacist about what to do if you do become unwell. So often, you know, people can be on the double whammy and their kidney function is sort of, you know, maintained. But then if they become acutely unwell and dehydrated, like someone has a gut bug or they're just not drinking enough and their blood pressure drops, that's really when these issues are definitely more common. So having an awareness of, if you are unwell or dehydrated, should you not be taking some of your medication? Should you be reducing dose of some of your medications? All those sorts of things. Ask those questions before you get to that point, so that you're not causing, you know, more damage.
That's very good advice. Thank you. All right. Well, thank you, Emily, again for your time and expertise in this area. Remember to hit subscribe. If you like the content in here, give us a like. If there's any specific information you want to know or hear from Emily, myself, or certain guests that we get in, please leave it in the comments below. If you want more information about what we do and about the program that we offer, you can head to www.kidneycoach.com. There you'll find a whole pile of information about the Kidney Disease Solution, which is a great big program that Duncan Capiciano and myself wrote to help support people diagnosed with kidney disease. And we also, you'll see Kaigenesis, which is the supplement arm, which supports that program. The thing I want to say about that is that the supplements are supplementary to the program. You can't just expect to take a pill and your kidney function improve. While it will definitely help, changing your diet and doing all of those other things that are mentioned in the program are just as important to go alongside that. If you need any more information about that or want to speak to our naturopaths, you can hit us up at support@beatkidneydisease.com, and either Emily or our another amazing naturopath, Rachel, will be happy to assist you. Okay, so Emily, thanks again. And until next time, stay well and be well. See ya.
Bye.